Good morning, everybody. Sorry for jumping the queue. I've got another presentation in another hall. So thank you, Dr. Arup and Dr. Nazreen, for this kind invitation. You see, when I was in school and before I joined med school, I thought I was good in mathematics and statistics. And when I joined med school later and did my post-graduation, I thought I was good at interpreting papers and studies. When it came to this topic, I realized that I'm a dumb guy. So, and Arup rightly allotted this to me so that I could keep it simplified, as much as I understand. So if you can understand that much, I think that's enough to go on. And thereafter, you have people like Ramesh, Dr. Arup, and Nazneen, Prashobh. They will kind of guide you to the higher level. So I'll keep to the basics as much as I understand. So, now a quick revision. If you make biometry errors in these three parameters, axial length, 1 millimeter error gives you a 3 diopter refractive error. Keratometry, 1 millimeter, 1 diopter, and AC depth, 1 millimeter is 1.5 diopters. So you can choose which one you want to make your errors in, and you can go ahead. So the problem with refractive surgery is standard keratometry methods don't apply because the corneal curvature has been altered. The standard formulae don't apply because the corneal power was based on your Virgin's calculations use the corneal power, and it's also used to I think predict the ELP. So with any system, if you put garbage in, you're going to get garbage out. So that is the problem with the refractive surgery. All your earlier measurements are practically garbage. So when we're talking of post-refractive surgery, we have LVC, that's LASIK, PRK, SMILE, LASIK, for myopia as well as hypermetropia, and we have RK. These are two different animals altogether, and they behave very differently. So now we come to the keratometry problems. The first problem that we have in LVC is that they modify only the anterior surface. So entire calculation was based on a fixed ratio of the anterior and posterior surface of curvature. So once the anterior surface is modified, you got everything going haywire. So now the posterior curvature was extrapolated based on the anterior curvature, so that entire thing is not valid now. In radial keratotomy, again, what we have is you may still maintain a fixed Gulstrand ratio, but then you have a smaller optical zone. So that's kind of another different game now. And then you have diurnal variation, long-term drifts because of the alterations in the cornea itself. Now, there is another problem with keratometry is the radius zone error. So what it means is basically in automated keratometry, what we used to do is we measure 3 to 3.2 millimeters, whereas in myopic LASIK and PRK, it's producing a larger optical zone, and hyperopic LASIK or RK, it's quite the reverse, so we're getting a smaller optical zone of 3 millimeters or less. So now these are the three things where we need to see the difference between the LVC and RK. So in a normal cornea, the spherical curvature is assumed, the anterior and posterior curvature have a fixed ratio, and you have a standard optical zone. These are the basic guidelines, three tenets on which everything is based. Now, in RK, what happens is, it's a flattened cornea centrally. The anterior and posterior corneal curvature may still be maintained, as I said, but the optical zone has been reduced. So, and the refraction will change to add insult to injury over time. In LASIK or PRK for myopia, if you look at this thing, so what has happened now is the anterior curvature is flattened. The anterior posterior curvature have got no relation now, and it's a larger optical zone. For hypermetropia, it's very much like the reverse. So you have a steepened anterior curvature. Again, that's not maintained, the ratio, and you have a smaller optical zone. So this is kind of all sorts of permutation combinations you have over here. Now, ELP, the IL calculation formula may differ in any way, in whatever way, but they do use the corneal power in assessing the ELP at some point in time in the formula. So if you have a myopic ablation, the formula incorrectly assume that the antechamber is shallow, so you have an anterior ELP and underestimation of the power, and you have a hyperopic result. So now the workaround or the remedies for post-laser vision correction is directly measure both anterior and posterior curvature, and thereby you get the net corneal power. So now you have the real corneal power. In post-RKIs, you have to take into account the optical zone also. So now K readings solutions over time, corneal topography has been used, Scheimpflug photography has been used, and OCT has been used. Different machines have integrated it differently. Now, there's something you must understand that there are terminologies which are very similar. SIMK is one, okay, does not confuse it, measures within the 1, 2, and 3 millimeter zones. Scheimpflug uses simulated keratosis, that's SIMKs, and there's something called EKR, the equivalent K reading for holiday. We'll come to that a little later. Now, there's something called total cornea power, or the true net K, or the true K. That's a software calculation. It's different from what the Zeiss Master 700 does, and that we'll come to that later. So, and OCT is another way of measuring the anterior posterior, the thickness of the cornea. Apart from the axial length, we measure the thickness and put that into the measurement of the corneal curvature and factors. It kind of enhances the accuracy of your. So EKR, if you look at it, if you look at post-RK eyes, if you look at the variation over here, within the same 4.5 millimeter zone, the variation is almost 12.7 diopters. So that is what needed to be taken. But this is now not relevant so much because the other formulae have taken care of this. In post-LASIK, that variation is much less. It's 3.3 diopters in the same 4.5 millimeter zone. Again, this is a more of historical interest. So if you go to the K reading solutions from biometers, the LS900, it's got 32 reference point, 2 circles. You got all that in the literature. IOL Master 700 does something good. That's total keratometry. And that's something new. So if you are having, I think Ramesh over here will be much better to guide you. I think you have a 700, Ramesh, do you? You have a 700? Yes, so he is in a better position to guide you on that. If you're having a lot of post-refractive surgeries, cataract, I think that would be the, though I have no financial interest and I don't own one either, so, but that would be the one to go for. And I do have a Tomy OA 2000, works good for most of your cases, but post-refractive you have to be a little careful and maybe a cross-checks here and there. So in the Tomy, what it does is, does topography simultaneously at 2, 2.5 and 3 millimeter zones, and it's got 9 Myers, so it gives you a fairly good idea, but it's mostly topography. So IOL Master 700 has brought in something called the total keratometry. Now, this is basically telecentric keratometry, measurement of the anterior corneal surface, and swept source OCT directly measures the posterior corneal surface and the corneal pachymetry. So it's basically swept source OCT doing all that. So, and you got multiple points. So it gives you an equivalent K, which enables you much better to calculate the standard IOL powers. Now, this is a post which I have taken from Dr. Ramesh, sir. So this is on social media post. Ramesh, I'm referring to your social media post. There's a social media post from you. So this was there, and I found this very useful. I think pretty much sums up. His concepts are pretty clear on this. So a stray social media post kind of caught my attention and pretty much sums up, your choice of keratometer post LVC eyes. So if it's a regular eye, manual K, auto K, optical, all are pretty okay. But if it's unusual, like the post-LASIK, PRK, or keratoconus, about 1 minute more? Yeah. Okay. So the true K values from 700 anterior, any OCT or Scheimpflug-based device are in that order of priority. And if it's a post-RKI, where the corneal thickness is not altered, but the central K is different from the flatter paracentral K, it's Zeiss topo or OCT-based and or auto K, optical K, and manual K in that order. So if you should know where you stand vis-a-vis your keratometer readings. So formula solutions have been either correcting the formula or the results. It's fudging one of them. Okay. So Barrett True K formula gives us based on its Barrett U2 and calculates a modified keratometry. It requires measured keratometries and refraction values before and after laser. But see, these are all more theoretical, so it takes care of all these 5 formulae. Now, what I wanted to say is, in this particular paper into 2020, it was found that the Barrett True K provided the lowest mean refractive prediction error. So that way, that is some evidence that we have. And this one, again, formulas combined with TK achieve similar or better results compared to coexisting no history or post-myopic laser refractive surgery formulae. This is, I think, a go-to place for most of us where we go, and of course, people who discern a lot more do a lot of other things. So these are standard tools where you can use it for myopic, hyperopic, post-RK. You input the data, and the best thing is it gives you results based on how much data you input. The more variables you fill in, the more accurate your results are likely to be, and you get calculations based on there are various formulae that it kind of gives us, the ASCRS platform, and it gives you various, so now you can compare and contrast and see how many, and if you would like to go on and refine that by adding a few more of the variables. So the same, so myopic classic and with prior RK, again, the same thing. You can fill in arbitrary formulas and get figures, and you can see that's how you get. So my recommendation would be it's history and counseling, consent. I think it's absolutely paramount that you might have refractive errors of different ranges. And if you can, you get true or total K values. Optical biometry is, of course, the order of the day. Target post-classic, post-RK target minus 0.5D, and post-RK target minus 1D. So the consensus and recommendation of Cornell power and calculations are constantly changing. Thank you very much for your attention. I hope I've kept it simple.
Since SUVEN will be leaving for another hall, so if there are any questions for him, he will take them. Yeah, or we can take up the questions later on. If SUVEN, you can come back.
I have one question. You had said on your post that post-RK, corneal thickness is not altered, so you prefer a size popo or a OCT-based system. So
Mic is not on, no?
I mean, you can use any one, right? You don't need to use, you can even use a pentacam.
Yes, you can. You just need to have a very small any measurement of a central small zone, like 2 millimeters or so.
But the flattening area that happens in RK can be from 2 millimeters to 3 millimeters to 4 millimeters. But you are worried about the central 3 millimeters.
Or less.
Or less.
The smaller the zone you measure, the more likely you are to be
so you are
accurate.
Suggesting in post-RK take the K reading from the pentacam?
Yes.
Or whatever topography?
Whichever will give you the central 2 millimeters or so.
Oh.
Not 3
But
millimeters
the new
and more.
optical biometers also do that, right?
Yes.
They are more accurate, in fact.
They go larger.
No, I'm using Antirion, and Antirion measures.
Antirion is also a topographer. I mean, it gives the
Like TOMI allows
it gives the different zones readings.
Yes.
TOMI allows you to calibrate the zones, how much you want, whether you want 2, 2.5.
Smaller zone.
Yeah, smaller zone. Right, thank you.